So good evening everyone. So good evening everyone, and I welcome you all to the amazing session of GAIMS Talk series, that is GAIMS Talk 7. And we are honored that we have today with us Dr. Tahmeed Saif sir, the legend himself. So let me talk something about GAIMS. So Global Association of Indian Medical Students is a global organization representing the medical students. The organization was created to provide a think tank that works to provide the highest possible standard of medical education to all the Indian medical students to be the best in the world. By working with all government, private, autonomous medical institutions and colleges, academicians and leaders, we try to provide the high standards of Indian health system. It is a non-political association working with constantly engaging global medical academicians and educators in bringing efficient and quality education and abiding by government leadership to present hints and suggestions to provide best healthcare to citizens of India and around the world. So, moving forward, I would like our DSOC Director, Global Health Education Society of GAIMS, Director Ashish, to take over from here.
Thank you, sir. Good evening, everyone. I am Ashish, the National Director of DSOC GAIMS. I welcome you all to today's webinar. Since past many months, we have seen and heard about the COVID-related aspects, but as we move forward, we have to understand this disease and their post-COVID complications, which can be a significant factor to be taken into consideration in the upcoming days. These complications can have a long-lasting effect on our brain, cardiovascular system, and especially lungs. So to give us an idea about these complications and their repercussions on our health, I would like to call upon India's beloved medicine guru, Dr. Tahmeed Saif sir. Sir is one of the most renowned faculty in the field of postgraduate preparation. Sir's passion of teaching medicine and his program concept, added with more than a decade-long experience, gives an extra edge to his. It's an honor to have you with us, sir. Over to you.
Hello everyone. So nice to be back with all of you. Right. So as you know, this is today's statistics, and what you can see here is that we've got around 92 lakh cases reported in our country with a huge mortality. And roughly what we understand is the post-COVID complication seems to be occurring in about 10% of the patients. So this number that is there is basically got from smaller studies. So what we are suspecting is possibility is there that for the next so many years we'll be unraveling more and more long-term sequelae and complications of this COVID. So just to highlight a few pathophysio points before we start discussing about the topic in general about the post-COVID complications. One of the things you will see is that the SARS-CoV-2 virus, which is there, has been really identified now. The genome has been identified, its various components have been addressed, and we know that the way it enters the cells is mainly via the ACE2 receptors, and there is something called the TMPRSS2 that helps in cleaving the spike protein, and that allows it to enter inside the cells. So this is how the virus is going to enter inside, and if you have heard of somebody telling that this is a virus that was developed in some lab and leaked through, discard those kind of theories because the virus is really way evolved. It took us a year just to understand the way it works, and it's really sophisticated. It uses a phenomenal number of techniques to evade the immune system, and the way it's getting caught is mainly because of the innate immunity initially. And what happens is it's able to enter inside via the ACE2 receptors. As I told you, the TMPRSS2 helps in its cleavage. We know that it enters inside and it starts replicating, but it has got a lot of evolved systems by which it's able to evade the immune mechanisms, and one of them, it starts forming small vesicles where it starts replicating inside these vesicles. So we've understood a lot, but one thing is becoming more and more clear. The more you read about this virus, you realize the amount of evolved system that it is. There's no way how a human could have developed it in some lab or some, those kind of things are just pure nonsense, and it's all conspiracy theories. Now, what really happens, we all know you have the innate immunity, we have the adaptive immunity. In the acute infection, basically the virus enters inside, it starts multiplying. Obviously, the type 1 immunity, the type 1 interferons, which are part of the innate immunity, have a phenomenal role. That much we've understood now, because more and more studies are coming out now suggesting that some people have got, about 20% of them have got a problem in the type 1 interferon response, and because this type 1 interferon response is defective in about 15 to 20% people, these are the people who go on to develop moderate to severe disease. Majority of us develop mild disease, and the reason for that is the good innate immunity that seems to be working. As you know, the type 1 interferons play a very important role in the innate immunity. So what really happens in the normal circumstances, that you have to have the initial response obviously is the innate immunity. The adaptive immunity kicks in when the TH cells are activated, and once the TH cells are activated, you will see that gemeral centers inside the lymph nodes start forming. We are now clear that certain patients do not develop these gemeral centers, means they do not develop antibody response at all. So although all this is covered, I think, in the previous lectures in pathology, I'm just rushing through them so that we can come back to the topic that we are going to discuss today, and that is that of the post-COVID complications. But to understand the post-COVID complications, it's really relevant to know as to what is the core phenomena, because ultimately we now know that the post-COVID complications are nothing but immune dysregulation. We know that it is relevant to cytokines. We are now understanding that certain cytokines we need to study in more detail, because they may be explaining many of the post-COVID complications. Right. So if you look at the problems in severe COVID, it is an inflammation that has gone out of control, or it is the antiviral load that is largely getting evaded. So what happens in this, as I told you, in certain patients, as I suggested, that the type 1 interferon response is not happening, or either there are antibodies against the type 1 interferon response. These subset of patients particularly seem to be progressing towards a moderate or towards the severe phase. So this is a study I was telling you. This is both published in Science. One is about a defect in the type 1 interferon, the other is antibodies against type 1 interferon. So more and more such studies are suggesting to us that the initial defenses are failing in patients who go on to develop severe COVID. And these are the patients who are these are the subset of patients. So actually the research seems to be progressing in such a way that very soon we might be able to identify, before the people who are exposed to COVID, as to who are the ones who might actually go on to develop a cytokine storm, and who are the ones who are going to develop severe. At least we do have in a small subset of patients that we know now the reason why they end up with severe, because a study showed that in people who develop mild disease and recover, and those people who develop severe disease and recover, one of the biggest differences that the type 1 interferon response is defective in those who are severe COVID. So I'm going through fast. In the acute phase, you all know the antiviral immune responses are going to be important. In the treatment we discussed at length in my previous lectures also, that in the initial phase the antiviral measures are going to be significant in our treatment. We don't use steroids in the initial phase. We don't use anything that is reducing immune system. Actually is good in the initial phase for us. It starts becoming a problem when it goes into a hyper response much later, and this hyper-inflammatory response is what we refer to as cytokine storm. The residual sequelae of a dysregulated immune system actually is the one that end up with resulting in post-COVID complications. So I'm just going through fast because all this is nothing but the pathophysio, and I'm sure this has been covered in the previous lectures. One of the problems we do know that there is lymphopenia, there is depletion of CD8 cells, and to some extent the suppression of the adaptive immune responses opens the door for secondary infections in these patients, and especially the patients who end up with severe disease, who are getting intubated, who are on mechanical ventilation, are the ones who are at high risk of picking up secondary infections, and that adds to the problem. In the pathophysio, you all know that definitely this is a disease that seems to involve all those cells that contain the ACE2 receptors, the nasal cells, the alveolar cells, the cardiac cells, the even the conduction system in the heart particularly seems to be having good amount of ACE2 receptors. There are now clearly evidence showing that even the GI, the liver, the renal cells also are having some amount of ACE2 receptors. So the amount of systems that are involved in the disease is significant. Here the virus is able to per se involve, and apart from that the dysregulated immune response is going to result in a prolonged sequelae that seems to create the problem. One of the core issues that we identified in this condition is just not a problem of inflammation. There is definitely a vascular component involved. There is not an inch in the body where oxygen supply does not occur. So blood flow and oxygen supply is the most important thing, and if that oxygen supply is not occurring and the blood flow is not smooth, regardless of, so as you can understand, the reason why in this condition you're seeing so much protein manifestation, every new day they're coming up with more. In fact, whatever CDC picked up and told that these are all the complications of COVID, now we are having people claiming that what you're telling is very less, we are seeing much more. So one of the reasons why simply is because you know that endothelium is there, is one of the largest tissues in our body. Blood vessels have to go everywhere, oxygen is required everywhere. So if you have blockage, if you have microthrombotic disease, if you have microangiopathy everywhere, then wherever vessels are blocked, obviously the consequences are going to occur. This explains why the disease is having such devastating wide problems in a subset of patients. And one of the core problems in this is the hypercoagulable state with thrombogenicity that seems to be an issue over here. Now how does that occur? Obviously this is going to involve the endothelium, so endothelial damage is one of the things. The other aspect that we know is that it activates the complement, and one of the ways how it does this is that factor H which is there, which is supposed to be an important regulator of the complement, this is blocked. So factor H getting blocked activates the complement. The complement also helps in damaging the endothelium. Endothelial damage per se activates certain adhesive factors, and plus you do have what we refer to as net. These are the neutrophil traps that are there, and they also create a mesh, a viscous mesh, and all these results in a clot that forms, and this clot that breaks into smaller thrombi can result in distal problems as well. So microthrombi is definitely a major issue that is there. So if you are looking at the pulmonary involvement, definitely endothelial injury is the starting point and the core issue that occurs in this condition. So that endothelial injury is going to progress towards involving the pneumocytes, so it goes into alveolitis, but definitely endothelial injury is an issue, and that results in a large significant amount of microthrombi. So what are all the various complications that are there connected with, sorry about this, right? So what are all the various problems that are there? You all know that we have the sequelae. Just to summarize it before we start discussing in more detail about some of these things, you have the neurologic and psychiatric problems, which I'm going to go into more detail. Obviously the pulmonary involvement is the most important. That's where the virus multiplies initially and spreads and causes most of the problems. So pulmonary sequelae is definitely an issue. We are now having new definitions coming up for post-COVID complications, and I'll tell you what those definitions are. We have the liver involvement, and especially in this you do see liver enzyme increase. Is a very common problem that you see in many patients. We have raised AST and ALT, and also the bilirubin can increase, but the amount of bilirubin increase is not significant. Most of it is mainly the liver enzymes that might be increased. So this is some kind of transaminitis that is there. The gut involvement is there, particularly the ileum can be involved, and we do see a lot of GI manifestations, and some of these can be sequelae, including the patient having anorexia and weight loss and difficulty in eating. So other problems are there. In some Chinese studies, they put forward that gut is the most common involved, although this is not in agreement with many of the studies that are published across the world, and I'll show you some of those. Obviously, myalgia and fatigue is the most common problem that is there in post-COVID. So fatigue, if you see, most of the studies have put forward as the most common problem that is there in a post-COVID sequelae. Now, they used to call this as long haulers, but they are now suggesting that this should be called post-COVID syndrome. So I think that syndrome definition or syndrome guidelines is going to come very soon. As I told you, as we are nearing the rise of the vaccines and vaccination, and to some extent control of this disease, so for the next so many years, some people are predicting almost 8 to 10 years, we'll be dealing with the complications that are left behind by this disease. So these include a variety of problems. Some of them you can see here. The patients, many of them are developing, strokes post-COVID. Some of them are developing myocarditis and myocardial infarctions. So it's a combination of problems, and why they are occurring we'll discuss. So the eye involvement is there, nasal obstruction, smell disorders, loss of taste. These are other issues that are there. Cardiac failure has significantly increased in post-COVID patients, and partly it is because of the inflammation that seems to be occurring in this condition, resulting in some kind of myocarditis. Renal involvement and renal sequelae are also going to occur. Then blood vessels, obviously important thing. It's a hypercoagulable state, so many of these patients have to be sent home on a anticoagulant, and in what basis we start anticoagulant is the area that should be interesting, and that is something that we will discuss. Finally, the whole process that is there to a large extent seems to be suggestive of a dysregulated immune response. So it is the dysregulated immune response that is heart of the problem in these patients. So especially those who are hospitalized patients, those who had the cytokine storm are the ones who are higher risk of developing the post-COVID sequelae, whereas the people with mild disease also are developing some consequences, but the number of those patients is not studied till now, and the number of them definitely is much lesser than those who are hospitalized. So in at least the CDC studies, what they are suggesting is that fatigue is the most common problem, and they saw in their patients that about 38.1% patients develop fatigue and increase in temperature. So fever as a consequence of inflammation, then fatigue. These are very, very common things that they found in their studies. Apart from cough, dry cough, many patients have got dyspnea on exertion is the other problem, myalgia, depression, some mild cognitive impairment, which results in what we refer to as brain fog, and then you do have some gut problems also. Now I'm just listing out the most common ones by looking at all the studies put together, the data overall collected by CDC. So this is more or less suggestive of what really happens, although this is not a comprehensive list. This is just, I'm telling you, the most important ones that are coming up again and again in multiple studies. So as I told you, regardless of which study you look at, ultimately the most frequent post-COVID problem seems to be fatigue, which seems to be lasting for quite some time. And we earlier used to think that is post-diabetic patients, diabetic patients, hypertensive patients, patients who are old, patients who have some pre-existing comorbid conditions. These are ones who might be having post-COVID. That is not the case. Now they are seeing even athletes, even children as young as 12 years. Now reports are coming. So we are now seeing younger people also developing post-COVID sequelae. On all these patients categories, definitely fatigue seems to be the most common. Now this is WHO. Now what WHO came up with, it came up with guidelines for post-COVID rehabilitation, and it came up with this suggestion. So what you can see here is most people with post-COVID-19 have mild symptoms or moderate illness. About 10 to 15% according to them develop severe disease, and about 5% become critically ill and end up in ICU. Now typically people recover from COVID around 2 to 6 weeks. In fact, you do know that majority of the mild cases recover within a week. The crucial days, as we discussed in acute COVID in our previous lectures, is somewhere between 3 to 10 days is a critical zone. So most of them, anyway, when they pass through this phase, they're going to recover by about 2 to 6 weeks. For some patients, some symptoms may linger on, and they might be present for weeks to months after the initial recovery. So you can see the timeline that they're showing. The exposure is there, and you can see majority of them are going to come out by about 2 weeks, but some of them continue for months before they start developing. In general, what they are suggesting is most people in most of the studies should recover by 6 weeks. So if they are not recovering by 6 weeks, then that is when you start defining as post-acute COVID and chronic COVID. So they came up with these ideas, and this is published in BMJ, but then officially this is not come out still, but then I'm sure that this is going to be accepted, because based on the WHO recommendations also, a significant number of people should start showing improvement by about 2 to 3 weeks itself. So what they're recommending is that if persistent symptomatology, that means whatever disease they had, whether it's breathlessness, whether it's cough, whether it is whatever in the acute COVID that they got, the symptoms, if they persist beyond 3 weeks, whatever initial symptoms that they develop, then that is called acute COVID. This is post-acute COVID sequelae or post-acute syndrome. Now, chronic COVID they are suggesting is after 3 months. So 12 weeks have passed, and after 12 weeks, if the patient still has the symptomatology persisting beyond this 12-week period, then this should be referred to as chronic COVID-19 syndrome. And they are giving rationales for that. So either way, these definitions might be relevant. You should be aware of them. Acute and chronic, remember the numbers. For 3 weeks, post 3 weeks, if the patient's initial symptoms have not subsided, whether they had breathlessness, whether they had dry cough, whether they had myalgia, whether they had fatigue, whether it is fever persisting for more than 3 weeks, whatever the initial symptoms were, if they persist for more than 3 weeks, you call it acute, post-acute COVID. And if they persist beyond 3 months, then this is referred to as chronic COVID. So easy, 3 weeks, 3 months. Now, there are multiple studies. This is basically phone study. Now we have apps that are collecting data. We have phone calls that are done to people to find out what the issue is. So this is the CDC data, as you can see below is the source that is mentioned. And in their CDC study, what they found is fatigue, again, as I told you, is the most important one. You can see it's right on top. And then after that is the cough. So fatigue is right on top, and then is the cough, and then you have the other things. So loss of taste or smell, headaches, body aches, diarrhea, nausea, chest or abdominal pain, confusion. This is what the CDC data is suggesting. Now, again, this is from CDC. What they're suggesting is COVID-19 sometimes can result in prolonged illness, even in young adults and children. So this is important to remember that, as I told you, we thought post-COVID or COVID as such is bad for people who are diabetic, who are hypertensive, who are having poor health, who are not doing an exercise. In fact, now studies are coming out of people who are athletes post COVID, the sequelae that is occurring in athletes, post-COVID sequelae occurring in marathon runners. So variety of studies are coming out now, giving a very clear idea that it's not just people who have comorbid conditions who are at risk of developing post-COVID sequelae. Although the risk in people who are hospitalized for more than 10 days is supposed to be higher, no doubt about that. But in general, now we are finding the problems in not just those kind of patients, but also in younger patients, including children. So there are many case reports for people who do not regain their previous health. Little is known about the clinical course. Obviously, the more time we have, the more we'll be able to understand about post-COVID sequelae. As I told you, this is going to be a issue that we are going to be grappling with for the next so many years. So this is not the end of COVID. And if you think vaccine is going to come and the issues resolved, it's highly unlikely, because a lot of survivors, as I just showed you, in India alone we have 92 lakh cases. 10% means that's 9 lakh people. So that's a pretty big number of people who might be developing the post-COVID sequelae. Obviously, the risk factors that even CDC is mentioning is high blood pressure, obesity, mental health conditions. These people are definitely risk factors for persistence of symptoms. But as I said, people who did not have any comorbid conditions also are developing post-COVID sequelae. So one of the pathophysio of why multi-organ injury is occurring and why it seems to be persisting, one of the things that they came up with is it could be direct cytotoxic injury by the SARS-CoV-2 virus itself. But more importantly, we're now understanding that a lot of things get dysregulated because of the infection. One is the RAS system getting dysregulated seems to be responsible. As you know, the RAS is not just about sodium and blood pressure control. It does have a lot of importance in myocardial remodeling, fibrosis. Many things are connected with RAS. So definitely RAS dysregulation is one of the things. And they are saying in the heart, the ACE2 downregulation is one of the problems. Okay, so this is one of the things to remember. It causes ACE2 downregulation. This is one of the things that is responsible for creating myocardial dysfunction in many patients who persist with problems despite having recovered from the initial COVID. Endothelial damage obviously is a core issue, and this is one of the reasons why you're seeing so many variety of symptoms. As I told you, every inch of the body needs oxygen and blood supply. You damage the endothelium and the flow of blood is affected, then anything can be affected. Ultimately, we know now it is a dysregulated immune response which is responsible for a low-grade inflammation, and this explains the fever, the myalgia, and the other variety of problems that seems to be occurring in these patients. So that means we know now it is not just the virus per se, the residual damage of the virus is there. It is dysregulated RAS, it is dysregulated immune system, and also endothelial injury causing the thromboinflammation. This thromboinflammation that is there, as I told you, can result in vascular problems, and vascular can affect any part, any organ. Dysregulated immune system explains the inflammatory problems that occur in these patients, and the RAS dysregulation to a large extent we are focusing on the heart over here. So long-term health effects of the coronavirus infection. This again the JAMA network. What they are suggesting is that persistent significant impairment of exercise capacity was seen even in SARS. So this is not something new in the sense we are talking about the SARS-CoV-2, but even the SARS-CoV-1, that is we are talking about the SARS that came in 2003. Even those patients had a lot of residual problems. In fact, if you look at the earlier studies as published, they found that 3.5 years after the diagnosis, 40% were still having some or the other sequelae after SARS. So even the past experience that we had of SARS virus, the coronavirus at that time, 2003, those people 3.5 years later also did have some sequelae. So this is not something new that is occurring only in the SARS-CoV-2. It was seen earlier also. And not only that, the SARS-CoV and MERS virus that had occurred earlier in the past, many of them had a problem reduction in Dlco almost 1 year later, and about 1/3 of patients were found to have depression, anxiety, post-traumatic stress disorder. So these problems were there, and all those patients who are admitted in the ICU, and regardless of whether it is SARS or not, post-ICU definitely does result in something called post-ICU syndrome. Especially prolonged ICU stay itself can result in a lot of problems. So persistent cognitive dysfunction, this critical illness syndrome that we talk about, it can occur in any patient admitted in the ICU for a long period, but it was definitely documented in SARS, in the MERS, and it is now we are seeing it in SARS-CoV-2 also. The weakness, fatigue, dyspnea, psychological problems, these though are anyway going to occur in prolonged ICU stays, but it does occur, as I told you now, in patients recovering from SARS-CoV-2 as well. So the way they are putting forward, this is October 21, 2020, and you can see what they are suggesting. This is broadly classified into acute infection, which can be asymptomatic, it can be mild, moderate, severe, or critical, and these patients might develop the post-acute syndrome. In the post-acute syndrome, definitely the multi-inflammatory syndrome is there. Now you must have heard of the multi-inflammatory syndrome in children, and I discussed this in my lectures. MISC we call it. Now they are talking about MISA. That means you have multi-inflammatory syndrome in adults also. So adults is also another thing, and guidelines and definition criteria for that also has come out now. So I discussed about children earlier. Now we're seeing in adults also, and this can be a post-acute COVID-19. Remember my definition: more than 3 weeks is post-acute COVID, and more than 12 weeks is post-chronic COVID. So this results in persistent symptoms and multi-organ dysfunction. As we also saw in children, MISC in children is multi-organ. At least 2 organs should be involved. Similar definitions you're seeing now in MIS occurring in adult. So there is a likely relationship between organ dysfunction and persistent symptoms that are not yet completely understood. That's what they are suggesting. Now this is one of the earliest evidence that we had that the SARS-CoV-2 is going to result into long-term complication, and this study came from Italy. This was March to April. All patients, 143 patients, they followed them up, and the mean hospital stay in those patients were about 13 days. These are hospitalized patients that they followed them up, and they assessed them after 60 days from the initial admission. So almost 2 months, that means post COVID, that they are evaluating these patients, and they found that only about 12% of patients in their study were totally normal. This is the interesting thing. So this was published in JAMA first, and then you notice that what they are suggesting again reflects what we are getting in multiple studies now, that fatigue is the most common problem. Progressive breathlessness, especially when they walk, when they talk, when they move, they start getting breathless. This is another problem. Joint pain, chest pain, cough, anosmia, Zika syndrome. Now one of the things we are seeing more in the day-to-day practice here in our country also is headache. So I really think in our studies you would find headache much higher up. But other than that, yes, fatigue here also is the most common problem. So variety of symptoms that they published, and as I told you, interestingly, only 12% of hospitalized patients that they had, and remember here they're not talking about outpatients, they're not talking about ward patients, they only followed up patients who are admitted in the hospital and who are discharged after recovering from COVID, and in their study they found only 12% were totally normal without any symptoms after they recovered and went home after COVID-19. Then we have an app now. Now is the era of apps, and everywhere we have apps coming up. So they developed an app for collecting data about COVID, and in which they were able to get 43 lakh people to participate in that, and they had a significant number of things. And what they found also is similar. Again, fatigue and myalgia and those things are common. This was again published in JAMA. This is October 5th, 2020, and there's long-term health consequences of COVID-19. And JAMA lists percentage-wise as to what problems are there and how the post-COVID clinic should come up now. now, we should have a separate set of team working for post-COVID clinical sequelae. Now, it does look a small percentage. You are saying that 10% of particularly those people who are hospitalized are the ones who are going to develop the post-COVID sequelae of the total number, sorry, not the hospitalized, of the total number who end up with the post-COVID sequelae. But that, as I told you, because the overall numbers in the world are so huge that those 10% also amounts to a very big number. This is the reason why I think now in the future we're going to have a lot of guidelines coming up for post-COVID, and post-COVID syndrome is something that we're waiting for. That syndrome definitions are going to come soon, and already definitions I told you, the proposed definitions 3 weeks and 12 weeks, but now we are going to get a more elaborate picture because WHO itself is coming up with more manuals, and I'll just show you some of the recommendations that WHO is giving about how to manage post-COVID complications. So no matter what, this is here to stay. Now I just showed you the CDC, the Italy study, the guidelines that they're giving. But look at this. Individually, you are seeing that many of the medical hospitals and colleges in the US are collecting their own data. And this is a study conducted in the School of Medicine. And what they showed was that in their study, they are whatever is the pink ones are matching with the CDC. What is not highlighted with pink is what they found themselves. So they are suggesting that the long haulers COVID-19 symptoms are far more numerous than what is currently listed in the CDC's website. So the individual, each of the thing, like Mayo's published some of its own data of what patients they are seeing, and other hospitals are publishing, and they are all not all incorporated completely into CDC still. So what CDC is listing out seems to be still the tip of the iceberg. We are now opening up to more problems connected with post-COVID, and the door becomes seems to be more wider now. We are now able to see more problems, and the list they are suggesting is much more bigger than what the CDC website is showing. So you can see that definitely the brain is affected, the whole body is affected, the eyes are affected, the skin symptoms are affected, and they are saying some of these things are not completely covered by the CDC website. And in their study, that is the medical school that I was showing you, their study, they found that painful symptoms were seen in about 26.5%, and most of the others were painless. In the painful symptoms, myalgia, headache were the most important ones. The feeling of burning skin, bone aches, these are all the important common ones that were there. Also, you can see GI problems like heartburn, neuropathy, abdominal pain, low back pain, calf cramps. These are other painful problems. So this painful thing covered about 26% of post-COVID sequelae. But about 70% plus did not have pain as a major issue, but fatigue and breathlessness were the major problems. So we'll just skip this. If you look at the pulmonary sequelae, obviously we know the pulmonary involvement is not just the alveolitis resulting in ground glass opacity or the progression towards ERDS. So it's not just the alveolar inflammation per se. Endothelium is definitely involved, and more than endothelium, we do know now that thromboembolic phenomena or thromboinflammation, as we call it, seems to be definitely a big issue. So any ARDS, as you all know, in the treatment guidelines also we discussed this, that ARDS is a shunt phenomena. You just can't treat by giving oxygen. The fact that these patients are responding to high flow nasal cannula oxygen is clearly suggesting this is not just a type 1 respiratory failure with shunt phenomena. These patients do have vascular component, and that's what we saw in the pathology also. Okay, definitely thromboinflammation is an issue. The blood vessels are getting blocked. It is diverting blood to the other area, so that's one of the reasons why oxygen seems to be working. And we discussed the management of acute pulmonary involvement at length in the other videos, but I don't want to go here into the details here because this is a post-COVID complication scenario. But it is relevant to understand that once you understand the patho is definitely there is a thromboembolic state that is there in these patients. Vessels are already getting occluded to some extent. Alveolar inflammation is there, which eventually is healing. But then there also about 5% of patients are having problems. Now, what are the acute manifestations? We discussed this. Pneumonia is there. Pneumonia can progress to ARDS, and hypoxic respiratory failure can occur. These are acute problems. Now, post-acute problems, if you see, these patients, about 53% of them in the follow-up 30 days after recovering from hospital, they followed them up and they notice that the Dlco, the diffusion capacity of carbon dioxide, is reduced. Now what this points is clearly the gas transfer is not occurring at the alveolar capillary interface. Possibility suggestive of some fibrosis that seems to be occurring over here. At the end of 3 months, they noticed that was seen only in 25%, which gives us very good hope that at least from 53% is gone to 25% at 3 months, meaning eventually many of the patients who would develop some breathlessness even at the time of discharge, who might have to be sent with home oxygen, they also over a period of few weeks and months, they are also showing improvement. Now there are very minority of patients who continue to get progressive fibrosis at discharge. These are the patients we need to follow up and identify, because there is a role now of using the drugs like pirfenidone or nintedanib for those kind of patients. But in majority of patients, as you can see, the inflammation as it seems to be coming down, it really may not be fibrosis, more of inflammation and the microthrombi which is getting cleared. That's one of the explanations why the Dlco might be improving in these patients, and it's about 25% decrease in patients have got decreased Dlco at 3 months. And also you notice about 71% of radiographic evidence of interstitial thickening and fibrosis is no doubt seen in some of these patients. But as I told you, a significant number of these patients, we are seeing that they show improvement over weeks. It's just a very small number of percent, about 5% of those who develop these problems, who ultimately end up with progressive fibrosis or prolonged fibrosis, which might need more additional treatment. On top of this, see, as such, hypoxia is a big issue for us, because if you're not giving oxygen, then in patient who is already having this kind of any kind of hypoxia is going to put a load on the heart. If the heart is not getting proper blood flow, and partially if already the blood vessels are blocked because of atherosclerotic disease, then definitely the heart is not going to keep up, because this is not a state that is there for when you're exercising or for a few minutes. This is there all the time, morning, day, night, every time. This prolonged hypoxia is going to put a load on the heart, causing persistent tachycardias, putting a lot of load on the LV, and this is one of the reasons why you can see that cardiovascular problems are increasing, and many of these patients 1 month, 2 months later are coming with acute myocardial infarction. Now the explanation for acute MI coming with post-COVID sequelae partly could be hypoxia, partly could be microthrombi in the heart itself, partly it is inflammation, and we discussed at length in our medicine lectures that any inflammation is bad for atherosclerosis because it causes plaque rupture. This explains why in renal disease, renal failure, which causes one of the causes of inflammation, atherosclerotic disease, rupture, plaque rupture and myocardial infarction is a common problem. So almost every disease, like say SLE you have, it's an inflammatory condition. Rheumatoid arthritis, it's an inflammatory condition, and definitely now we are understanding all inflammatory conditions, the risk of myocardial infarction significantly increases, because inflammation per se, as you all know, the most sensitive marker for ischemic heart disease, highly sensitive C-reactive protein. The reason for that is, as I told you, inflammation correlates with weakening the plaque and allowing rupture of the plaque, causing myocardial infarction. So those are the consequences and those are the issues that we are dealing with. Now pulmonary, if you look at the nuclear medicine studies, initially inflammation had affected the lung. Progressively after 6 weeks at discharge, you can see most of the inflammation is cleared. About 12 weeks later it is significantly decreasing. Now there are multiple studies, and this is an interesting one. They found follow-up patients. They were looking at who are the ones who are going to have problems in pulmonary function tests. One of the big clues you get in the CT score itself, those people who have abnormal CTs, those people who have abnormal CTs end up with higher amount of pulmonary function test abnormality. Those who had a normal CT or mild CT involvement are the ones who are going to have less abnormalities and less pulmonary function tests abnormalities in follow-up. This makes sense then. Obviously all those patients who had significant disease, based at least on the CT score, I'm sure now in the future we're going to get guidelines that if the CT score is high, severity score is high, those are the patients we need to follow up to see progressively how much is the pulmonary fibrosis, is it decreasing, is the inflammation coming down, is the patient worsening, because we do see now a minority of patients, as I told you, for somehow it seems to be activating a fibrotic state and progressive fibrosis occurring in some of these patients. So what this study showed was that overall about 16% of patients had a decrease in DLco, FU and FVC was decreased. Definitely overall lung volumes, if they're decreasing, it's nothing but a restrictive pattern suggesting of fibrosis. So these are from AIMS, and you can see the AIMS images. Definitely you can see that the initial ground glass opacities that were there, they seem to be clearing out after some time, but some of these patients do have this fibrosis, and you can see these pockets of fibrosis that are nicely shown in the HRCT. What AIMS is suggesting is that people who are going to develop pulmonary fibrosis, they have clear risk factors. What are the risk factors? Risk factors are age more than 65, so obviously elderly people. But as I told you, that doesn't mean young people will not develop post-COVID sequelae. It's just that the percentage of them getting affected is much lesser. So age more than 65 is a risk factor. If they have severe illness, naturally, one of the things we understand is the more the comorbidities, obviously the higher the risk, but that doesn't mean those who don't have can escape. They also, but the percentage is much lesser. Definitely we are now understanding that mechanical ventilation, those who end up on the ventilator, There now very clear, more recent studies are showing that lung protective ventilation, if you can do, then that seems to be highly beneficial in preventing progressive fibrosis as the patient recovers. Smokers obviously at high risk, and chronic alcoholic obviously as at a higher risk of developing pulmonary fibrosis. So these are all the risk factors that they've listed out, who are the potential ones who definitely need to be followed up. Now we don't have clear guidelines, even in the national guidelines we don't have, although broadly what we are thinking is 6 to 8 weeks is one of the first visit you should get the patient back again after he is discharged from hospital, and then again 3 months should be the follow-up time to evaluate the patient and see what he is, how he is doing after his discharge from hospital with SARS-CoV-2 infection. So one of the issues is should we start these drugs, perfenadine and nintedanib, which we use for radiopathic pulmonary fibrosis in all patients, and clear guidelines, and at least what the discussions going on in AIMS is suggestive is that, at least as based on the ICMR and the national guidelines I'm telling you, is that they are saying that definitely all patients at the time of discharge will not benefit by these drugs, because these drugs work in a condition where progressive increase in fibrosis is occurring. As I told you, in a significant number of patients, the Dlco starts showing improvement over a few weeks. So in all these patients, starting these kind of drugs, it definitely doesn't make sense. However, there is a significant role of using steroids, and steroids at the time of discharge, particularly in those people who have desaturation at the time of discharge, who need to be sent on home oxygen, it makes sense to start these patients on steroids. And 0.5 milligram per kg prednisolone with tapering doses over 6 weeks is generally the thing that is followed in people who do have significant inflammation in the lung. And in addition, if you have benefit of getting the inflammatory markers and they are raised, you do understand that C-reactive protein rises very fast. ESR takes time to rise. ESR actually might be a more important marker at the time of discharge, because CRP rises rapidly and comes down. The ESR is the one that might be persistently elevated in the later stages. So either way, if the inflammatory markers are increased, then steroids definitely have a role. And again, you can't put steroids in all patients at the time of discharge in SARS-CoV-2. It is those patients who do have desaturation at the time of discharge, who have to be sent home on home oxygen. These are the candidates who might benefit on starting on steroids. And I told you the dosage. Obviously, perfenadone you're going to evaluate in your second visit. I told you second or third month. The 6 weeks or 8 weeks, that the pulmonary function test, you need to correlate with the third month PFT. And if you notice a trend of increasing fibrosis, that is now suggesting that is a progressive fibrosis. And any progressive fibrosis, these drugs will have benefit. If there is no progressive fibrosis, then there's no point in starting these drugs. Obviously, you are aware that already significant pulmonary fibrosis has occurred in some patients, and this is one of the first lung transplant done for the COVID survivor in Chennai. Now, what the WHO is recommending is post-COVID, definitely you need to have clear follow-up, clear guidelines, priorities. One of the things that we understand is graded exercises over 4 to 6 weeks will definitely have a significant benefit. So this is what we refer to as the pulmonary rehabilitation. The British Thoracic Society is suggesting that if a patient has got chronic cough for more than 8 weeks, then this is a patient that needs to be evaluated. One of the recommendations given in the WHO manual is spaced breathing. What we understand is that in patients who are developing dyspnea at the time of discharge or post-COVID, if they come back with you with discharge, your problems could be a pulmonary issue, it could be a respiratory problem, it could be a cardiac issue. You need to find out whether it's a cardiac failure that is causing. So echo and evaluation of the heart is going to be important. The other can simply be an anemia. And so it's not just anybody who comes with breathlessness, you just can't say it is because of this. But one of the things that is definitely responsible for creating some kind of dyspnea is supposed to be weakening of the diaphragm. So some kind of reconditioning of the diaphragm has to be done, and good breathing techniques are supposed to be very important. So what they are suggesting is this 12 to 15 bursts are nothing but the way that we do in yoga. So the breathing techniques that we use in yoga are definitely going to be beneficial over here. So basically they're trying to suggest you need to tighten up the diaphragm and strengthen it. Breathe in through the nose and breathe out through the mouth, forceful breathing out through the mouth. But all this has to be done slowly, and slowly a staggered improvement should be done. Increase in these exercise activity should be done. So definitely fatigue itself of the diaphragm could be one of the factors, and strengthening the diaphragmatic muscles with good pulmonary rehabilitation, good exercises is going to have a significant benefit in these patients. Sleeping in the right posture and trying to do these breathing techniques, again these are all given in the WHO manual, and you can see breathing in through the nose and breathing out through the mouth, and trying to make the diaphragm work and strengthening the abdominal muscles. All these are going to help benefit. This is a posture that that they have found to have some benefit in the post-COVID. Obviously, remember in the acute COVID we discussed about the constant changing posture, and this even whether they are non-invasive ventilation or the acute patient who has hypoxia, we discussed about 2 hour technique of 30 minutes to 2 hours. Patient should be lying in different postures. That's an acute scenario. I'm now talking about people who have got weakened diaphragm, what they can do in the weakened chest muscles and diaphragm, what kind of breathing techniques they can do to improve. Now obviously WHO has given a manual itself giving various exercises that can be beneficial in this aspect. Now this is a study again in France. Now what they did was that they wanted to look at all the data that we had up till now was hospitalized patients, and the France study was basically they called up people. There's again telephonic survey of 120 hospitalized patients, and then they looked at 96 ward patients, and to their surprise they found that a significant number of ward patients also had fatigue and dyspnea and loss of memory, that brain fog we talk about, where they can't concentrate and the memory seems to be affected, some kind of mild cognitive impairment that seems to be occurring even in ward patients. Now this is interesting. We thought it is hospitalized patients. Now this study in France at least is suggesting that there also in patients who are not that severe to get hospitalized in the ICU, even those patients who got discharged from the ward, they also end up having some of these problems, and the mean age and the males obviously are more affected in COVID. As you know, any hospital you end up, the amount of beds occupied with the females is almost 1/5. A significant number of patients inside the ICU you will see are going to be males. So what their study suggested, and this is 2020 article again, August 25, infection, Journal of Infection. You can see that their experience from the ward patients at least also is not that all ward, a significant number of ward patients also do have some post-COVID sequelae. So it's not just severe hospitalized patients. Finally, the question is, we have hospitalized patients who are ward patients, we can consider kind of like moderate. ICU patients like severe. We're talking about mild patients, those who don't get hospitalized at all. Do they develop? And that is something that needs to be studied, and unfortunately we don't have adequate data in this particular aspect. Now this is being collected again, a telephonic survey of 292 adults, people who are RT-PCR positive, outpatients, and they were interviewed at 16 days. And this study again, this is a telephonic survey that was published, and they found that 35% of these patients who were symptomatic had not returned to their normal usual health. So obviously you can notice that hospitalized patients, the percentage was higher. These are outpatients, and at 16 days after they developed their problems, and they were totally, 35% of them at least were not come back to totally normal healthy state. So finally we are moving to the cardiac problems. Now obviously the two biggest issues that result in morbidity and mortality are the pulmonary and the cardiac. So definitely cardiac involvement, and one is, I told you directly, it is the direct cardiotoxicity. One of the things we now understand is not just the myocardium, we also understand that the conduction tissue per se is known to be having ACE2 receptors. So conduction abnormalities, arrhythmias, nodal dysfunctions are seen quite commonly in patients with post SARS-CoV-2. So we know that hypoxia mediated itself is an issue, as I just explained to you. Hypoxia, anemia put a problem in the supply demand mismatch. How much oxygen is required by the muscle in a patient who has got hypoxia? Definitely cardiac output will increase. Patient goes into tachypnea. To get more oxygen, the heart has to beat faster to get more blood and pump it out. Now to do that, it needs more oxygen per se for itself, and if partially the patient already has atherosclerotic disease, now the demand is going to increase, the supply is going to lag behind, partly because of previously obstructed vessels. He already had atherosclerosis from 10 years. It was 50% already occluded vessels. On top of that, this patient got a hypoxia. On top of that, he might be having the anemia. All combined result in complications. So this is what we are talking about, the supply demand mismatch. The cytokine storm itself is per se damaging to the myocardium. The acute coronary syndrome that does occur in patients who have acute COVID. So many patients with COVID may present initially itself with acute myocardial infarction. This explains why almost all patients that are coming with acute chest pain now, we just don't do the ECG and start our typical management where we do PCI within 2 hours, or thrombolytics. The trend is now shifting more towards thrombolytics, because you might be hesitant to take a patient with CoV-2 positivity unless you're testing, and even if you're doing CBNAT, it will take about 3 to 4 hours for you to get the report, at least in our country. So this explains why hardly most patients we are doing the PCIs now. A significant number of patients are getting thrombolytics, and the pharmacoinvasive technique is followed. So they get thrombolytics, we get the result of the SARS-CoV-2 RT-PCR, and then we are going to get a invasive technique done. That is, we do the angiogram and we fix the vessels that are occluded. So definitely acute MI is an issue. The problem is more about the management of acute MI. The bigger issue obviously in our country is the stigma associated with coronavirus. So patients who are getting chest pain, who would have normally gone to the hospital immediately, are hesitant to go because they are worried that they'll get pick up coronavirus in the hospital, and they try to do some home therapy, which again results in delay, and any delay, as you know, an acute myocardial infarction is catastrophic. The other problem that we're noticing is the arrhythmia. And this arrhythmia, we are seeing particularly post-COVID sequelae, a significant number of patients developing tachycardias, a lot of patients developing bradycardias, a variety of problems, and I suspect partly this is because of the myocarditis, and partly is because of the conduction abnormalities that are known to occur in these patients. The other issue that we are seeing is the venous thromboembolism, and that venous thromboembolism itself can result in more load on the myocardium, and ultimately once heart failure, the path to heart failure starts. It's a one-way track. It's a one-way traffic. You don't have a reverse gear in that. You follow from stage A to stage B to stage D to stage D. All those patients who are already in stage A can progress to stage B and stage C. That movement to the next stage occurs faster if they are having an insult of COVID-19 on top of the pre-existing problem. So the cardiovascular sequelae, interestingly, one of the things that we saw is this large study from Frankfurt, and they followed 100 patients up 71 days after they were discharged from the COVID, and they found that almost 78% of these patients had MRI showing myocardial inflammation. This is scary now, that a patient who was SARS-CoV-2, he was declared cured, he was sent home, and now 71 days, that means you're talking about more than 2 months after the patient is discharged. They found, obviously echo doesn't pick up myocardial inflammation that well. Myocarditis is definitely the sensitive tool for that is MR, and MR is able to show significant number of those patients had myocarditis. So nowadays we see so many patients who tell us ki I had COVID a month back, but now I'm getting palpitations, now I'm getting things. So yes, if you do an MR, you might be able to show that they have inflammation in the myocardium. The question is, do steroids benefit such patients? They have myocarditis, no doubt. Now the answer is ki whatever short studies were done did not show benefit. So what do we do in these patients? We go mainly for supportive treatment in these patients, and obviously they need to be followed up. They got bradycardia, that has to be treated. If they have got tachycardia, we put them on metoprolol, and it's just supportive treatment to a large extent, because a significant number of these patients, each day by day as it progresses, they start showing improvement, and whatever palpitations, whatever issues they have, they seem to be improving. A significant number of the patients were also found on echo to have decreased LV ejection fraction. So there's other issues that were there, not just the myocarditis picked up by MR, but other problems were also seen in this particular study. So in general then, acute cardiac problems are cardiac injury, acute cardiac injury, myocarditis, arrhythmias, cardiogenic shock, and thromboembolic disease. These are acute problem. Now post-acute manifestations is the myocardial inflammation that results in myocarditis. Any inflammation might heal with scar, and around the scar re-entry tracts will form, and that results in arrhythmias, and out of patient cardiac arrest can occur. One of the things that a large study in Italy showed, that the number of cardiac arrests out of hospital doubled this year compared to the last year. So this obviously a scary problem that is there. Now the question is, what are you going to do about this? Now, should all patients post-COVID be started on cardioprotective medication? The answer is definitely no. If it's a young athlete, there's no point. If patient has got already hypertension is there, diabetes is there, he's got the risk factors, then anyway we're going to evaluate such patient to start them on statins, to start them on aspirin, to those things. Now in the acute COVID, obviously in a condition which is going to have thrombocytopenia, you're not going to start the patient on aspirin. And on top of that, you're putting the patient on anticoagulation. Are you trying to provoke the patient enough to develop intracranial bleed? Definitely not. So we don't start aspirin in all patients just because they are likely to develop cardiac problems in the future. But we are taking patient individual by individual and trying to evaluate, does he really need cardioprotective medication, which includes RAS, which includes statins, which includes aspirin. Now we're going to give it if the patient is deserving, not just because he's got COVID, but he's got diabetes, he's got hypertension, he's got any pre-existing ischemic heart disease features, then that risk factors, then he definitely gets it. But other than that, as I told you, we're going to evaluate whether the patient should be sent home on anticoagulation by using a scoring system called the improved D score, and I'll show you that score later. But aspirin is not something that you automatically give to everybody. This is an important idea to remember. So the various pathophysios that they published, and this again to the 23rd October study in Science, and they are trying to tell about the ACE2 receptors getting downregulated, that might result in the alteration of the myocardial, how it heals with myocardia. The myocardial healing process is affected. SARS-CoV-2 directly can cause problems, but more likely in the post-cardiac sequelae, it's the indirect damage that seems to be mainly because of the inflammation and the thromboinflammation that seems to be creating a bigger problem in patients with post-COVID sequelae. So this is the study published in JAMA, and this is again 2020 July 27. If you can't see the date, I'm just telling you. This is what I was telling you. This 100 patients, the same Frankfurt study, it's the same thing. So this is 71 days MRI showed that 78% had cardiac involvement, and this is what I was telling you, the scary scenario that almost 2 months later, 78 is a big percentage of patients who are having cardiac problem. That is particularly myocarditis. Now, we thought it is more of a problem with comorbid patients. As I told you, it's not just comorbid. The risk is lesser in people who don't have diabetes, hypertension, all that. But the risk is definitely there. And this is a study, again, JAMA, September 11. I don't know if you can see the date over here, the September 11, 2020, JAMA Cardiology. This is competitive college athletes. Okay, this is not some old Buddha we're talking about. We're talking about college athletes here who are RT-PCR positive. None of them were hospitalized. Majority did not report symptoms. Almost 46% had evidence of myocarditis or prior myocardial injury by cardiac MRI. So this again, as what I was trying to tell you, although the percentage compared to 78% there, this 46% is lesser. But it is worrisome. The young people who are developing COVID, who are not having symptoms, who are not hospitalized, who are 46% of them are having some inflammation in the myocardium, and that is the thing that we need to be worried about. So this explains why I think in the future we are going to have a lot of COVID clinics. Post-COVID management itself is going to be a topic, and it's going to be a significant issue. It's not something that is just come for 1 year and is going to be wonderful life after this. It is going to leave behind a lot of problems for us, and this mess we have to clear up over the next coming so many years. So these are recommendations by so many, what European Society of Hypertension is telling, what Canada is telling, what American College of Cardiology is suggesting. I don't want to go into so much details over here. Moving to the neurological problems. In the neurological, we have brain fog, that is some kind of confusion that these patients develop, and mild cognitive impairment. They can't concentrate, they can't think rationally, and this is scary because imagine if you're preparing for some exam like NEET and you develop this and then you can't concentrate. That is really scary. So the other problem that seems to be there is the neurological effects, the mental effects that seems to be smoldering like a volcano, or smoldering, and it's going to be a long-term problem. So broadly then, what JAMA Neurology published, this again 2020, and what it is suggesting is acute problems are headache, vertigo, paresthesias, all these are the issues, encephalopathy, seizures, strokes, and GPS. These are all acute manifestations. Now post-acute mainly is the cognitive impairment that is there, and the brain fog that we're talking about, some kind of fog where they can't see clearly, they can't think clearly, they are not able to focus properly. Those are the common issues, and we put together not just neurological but neuropsychiatric problems. So there are various studies. I can keep on showing you the studies and the various percentages about the patients who have got so many issues. Obviously, encephalopathy, ischemic stroke, intracranial hemorrhage, encephalitis, Bell's palsy, all these are acute problems, and these can leave behind sequelae. You got a stroke, you're not going to magically improve in the next few days. You're going to have the residual problems over the next so many months connected with that. Now, anosmia, interestingly, was something that we see as kind of classical feature of COVID. Somebody's got anosmia, ageusia, left eye conjunctivitis. We know that that is nothing but COVID. So when the vice president's debate was going on in US, that is Mike Pence on one side and Harris on the other side, Kamala Harris on the other side, he had left eye conjunctivitis. They were not able to, we Indian doctors, we knew that guy has got COVID. And much later they came out that he's got COVID. Left eye conjunctivitis definitely is a feature suggestive of COVID. Anosmia is a feature, ageusia is a feature, and what they found in their study was significant number of patients improve by 3 weeks. What is unfortunate is a minority of the patients don't improve over months. Some of them are yet to improve, so we are going to wait and see how long ultimately they will improve, or whether they will really improve, get their smell back and taste sensation back or not. So that is something that has to be studied, but those are really a minority. So renal is another issue that is there. You have acute kidney injury, hematuria, proteinuria. Histopathology, what they found is two main things: acute tubular necrosis. Now this is a combination of problems. We keep the patient in a dry state because any lung inflammation, we don't give fluids and flood the lung. Another thing is glomerular pattern. They can get proteinuria, and they found that is FSGS, and it's called collapsing FSGS, and this is now referred to as COAN. COAN is COVID associated nephropathy. So this is nothing but a type of collapsing FSGS. Just like how we have HIV associated nephropathy, HI1, same thing here, COAN, we talk about as acute problem. Post-acute, obviously, 31% patients unfortunately ended up on dialysis, requiring renal replacement therapy or dialysis at discharge, and 37% were continued to have renal dysfunction, even though they did not need dialysis, but they had a lesser GFR. Now, obviously, renal sequelae are much more in older people. This is because as we age, every year, the GFR reserve that we have keeps decreasing. So that decreased reserve itself is a risk factor. On top of that, it depends on how severe the disease was. Don't forget, remdesivir hits the kidney. All the drugs that we're using going to affect. Plus, any infection the patient develops in the hospital is going to hit the kidneys by creating some kind of sepsis. All the toxic drugs that we're going to give is adding to the problem. On top of that, we are trying to keep the patient in a dehydrated state, not allowing the kidney to flush out all the toxins nicely. All these are going to be issues that result in renal sequelae, and this is also something that has to be carefully managed. One big issue, as you all know, is thromboinflammation. So vascular complications. The question I've seen many people ask me is, should all patients at discharge be put on anticoagulation? Definitely no. What now we have clear guidelines, and is followed in AIMS also, is we are now using something called the improved D score, improved D score, and the score more than 4 is relevant for us. Some people simply use D-dimer. If D-dimer is more than 2 times normal, they should be put on anticoagulation at discharge. Now that better is to use the scoring system, and the scoring system is we calculate the score. Obviously in that D-dimer more than 2 is also there, and ultimately based on the scoring system we decide should the patient be sent home on apixaban or rivaroxaban. The oral anticoagulant agents are preferred agents over here. So obviously the decision of whether you're going to anticoagulate a patient, because we don't want the patient is going to go home. Many of these patients are going to be on home oxygen. Many of them are going to be bedridden. Anything bedridden, as you know, if the calf muscle is not contracting, we are asking for trouble now, because deep vein thrombosis will hit the lungs, causing pulmonary embolism. So what we need to do obviously is rehabilitation is one, means you need to put the patient to get him mobile first. But the other thing is you're going to make a decision of starting anticoagulation based on this scoring system. Mental health obviously is a big issue. Anxiety, big problem. Then we have stress that is affecting the patient. So anxiety is an issue, stress is an issue. They are isolated from family. They're going to be shifted to a room. If they're in the hospital, they're not talking to anybody. So isolation itself is going to be a problem. Definitely the hopelessness that comes along with this disease. And in particularly doctors, one of the issues they're seeing, doctors who suffered with COVID started developing PTSD more commonly than the lay people. Exact reason we don't know, but post-traumatic stress disorder, the nightmares of waking up with a non-invasive ventilation BiPAP tube, and being in the hospital and other problems. So PTSD was an issue, and now they are suggesting that we need to have PHQ-9 questionnaire at discharge for most patients to be able to pick up do they have neuro problems or psychiatric problems or not. And this is what is the PHQ-9 square, questionnaire. If the questionnaire hits a particular score, then we know that this patient needs to be referred to psychiatry. So as I told you, depression is an issue, bipolar disorder, post-traumatic stress disorder, psychosis, obsessive compulsive disorder, epilepsy, all these are problems that have been documented in a post-COVID sequelae. So emotional disturbance is definitely there, and as you can understand, the people who are affected most are the old people. They are having depression, they are already having some brain fog, that is cognitive impairment. They start losing weight. They are initially, whatever interaction they had with people, communication, the independence that they had is all gone. So all this meeting people in the park and talking, all this gets disconnected from them once they develop this disease, and that is going to further increase the isolation and further increase the depression and other problems that are known to occur in these patients. So they are more susceptible, and they are the ones definitely that needs to be watched out for. To summarize then, heart is affected, lung is affected, brain and nervous system. So in the heart, obviously heart muscles, heart failure is a big issue, myocarditis and heart failure. In the lung is the lung tissue fibrosis, restrictive lung failure that can progress in some minority of patients. Although most patients with pulmonary involvement, I told you, if they are requiring home oxygenation at the time of discharge, we send them on tapering dose of steroid. That works. Brain is a big problem for us. Loss of sense smell typically improves by about 3 weeks, but in some patients it may take months to improve. So thromboembolic events can be a catastrophe. It can result in stroke and all those issues. But the big problem is the memory, the concentration, and headache that are not mentioned here is becoming pretty common in post-COVID sequelae. Mental health is definitely a problem now. So I'm sure in the post-COVID guidelines, psychiatric role is going to be a major issue, because definitely this disease is going to leave behind a lot of psychiatric complications. Fatigue, myalgia obviously are the top problems that have to be handled. Now, how do we handle this? Obviously, this is what I was telling you, this multi-inflammatory syndrome in adults we talked about in children. Now this is already come, this is June 2020, and MIS in children, like Kawasaki's disease, we discussed in our lectures. Now we're talking about MIS-A, and the working definition that they're giving is severe illness requiring hospitalization in a person aged more than 21. Remember, MIS-C in children is less than 21, this is more than 21. A positive test result for current or previous SARS-CoV-2 during admission or in the previous 12 weeks, severe dysfunction or more extrapulmonary organ system involvement. Then lab evidence of severe inflammation, which should be CRP, ferritin, D-dimer, interleukin 6, whatever. Absence of severe respiratory illness. Absence of alternative diagnosis like septic shock. So two major respiratory severe illness and septic shock you got to remove. Rest of the things should be there. And if you have all these, then that is suggestive of multi-inflammatory syndrome in adults. So obviously now in children it was a recognized thing, but now in adults also we do have this kind of syndrome, and now we understand the pathophysiology is nothing but dysregulated immune problem. So obviously there's a huge number of extrapulmonary complications. Some of them are persisting, particularly some of these cardiac issues, endocrine issues. A lot of people who are pre-diabetic progress to diabetes rapidly during COVID. And normally HbA1c is around 6, 5.7, 6, 6.1 for years before they touch 6.5, which is the number where we say this is diabetes. But many patients progress through fast into diabetes once they develop COVID. And the idea there could be interleukin 6, they are suggesting, that can cause inflammation of the beta cells. So there are multiple theories about why diabetes is increasing in risk, particularly post-COVID. So thromboembolism, neurologic problems, hepatic, renal, we discussed many of these things. What the WHO came up with a manual about how to do rehabilitation, and they feel that rehabilitation forms an essential core feature of the COVID-19 illness. And particularly people who have breathlessness, they gave a lot of exercises. Postures are very important, and it starts with that, positions to ease breathlessness first of all. But apart from that, the paced breathing I was telling you, better is the yoga that we do, the pranayama and other things, they are obviously more important. So that is going to help. Exercising after leaving hospital, and there is evidence to prove, obviously there's no direct evidence, but there's indirect evidence based on what we saw in athletes, sportsmen who are returning to exercise, and we follow something called the Stanford Hill statement. So this is evidence based guidelines. So post recovery they are suggesting the patient should do stretching exercises. So first starting point in post COVID to reduce the fatigue and myalgia is going to be the stretching exercises. After that, the patient should start walking, to start increasing the exercises. So over a period of time, it's staggered improvement in exercises, and each day they should push themselves more to do more and more, and that is how the road towards reducing this fatigue is. Because as of now we don't have any drug that can help in reducing fatigue, and many of these problems that are sequelae. Warm-up exercises, WHO manual is giving this. This is the manual suggesting so many warm-up exercises: shoulder shrugs, shoulder circles, side bends, knee lifts, ankle taps, ankle circles. All those are warm-up exercises. They are also giving cool-down exercises. Obviously, the patient can go to warm-up exercises, then go to cardio, slowly increase there, and then go to muscle-building exercises. And then you also have suggestions of cooling-down exercises, of again stretching exercises, basically that have to be done post muscle building exercises. So what they're suggesting for attention, memory, thinking is again physical exercise, but brain exercise is added over here. The patient should try to solve puzzles, should do more hobbies. Obviously, one of the things he should not do is keep watching YouTube and watching movies. That is going to just make the patient more worse. So, but challenging the brain is one of the ways how the patient can improve. So basic needs, definitely sleep quality is very required, and we are now seeing a lot of patients post COVID are having sleep problems. So good quality sleep, eating sufficiently, physically being active, staying socially connected, relaxing activities, gradually increasing involvement in daily activities. All these are recommendations that the WHO manual is suggesting. Now obviously we already crossed more than an hour, that the time that was allotted to me. I would have loved to talk more about this topic. Obviously in the future, I'm sure in the coming years we're going to have our hands full dealing with the post-COVID sequelae, and I'm sure the syndromes, we're not going to call them long haulers or anything like that in the future. I'm quite clear that they are going to call it a syndrome, and more definitions of syndrome and a management of syndromes are going to be an issue. Right now we are dealing with the acute COVID, and as the vaccines start coming in, and I'm sure that we are going to turn our attention significantly towards the post-COVID sequelae and the management of that. I thank the organizers for giving me this opportunity to talk on this. Unfortunately, I could not look at your questions because my hands were full just looking at this itself, presenting this itself. But anyway, I thank so many of you have participated, and I enjoyed doing the session. So my thanks again to the organizers. I'll just hand it over to them.
Thank you so much, sir, for a wonderful session and providing an insight on this topic in such a short time. As upcoming doctors, this was a much needed session, and we are very happy to learn from the best. We would also like to extend our thanks to Dr. Shubham Anand and all the organizing team of GAIMS for their constant efforts and support in bringing these informative webinars. Thank you for joining. Looking forward to have you with us on other events organized by GAIMS.
Thank you so much. Thank you, Dr. Shubham, and thank you, Anis. Thank you, Aziz. Thank you.